Okay, let's dive right into this explainer. Today we're looking at a truly fascinating biological paradox. We're going to explore how two of the most heavily discussed substances in psychopharmacology borrow the exact same neurotransmitter in the human brain, but use it in completely, fundamentally opposite ways.
Think about it. How is it even possible that a single point of divergence in our microscopic neurochemistry can cascade into totally different psychological states? I mean, we're talking massive differences here, completely different affective dosages, totally asymmetrical safety profiles, and wildly distinct applications in modern clinical therapy.
There's a brilliant quote from the source material that hits the nail on the head. Same molecule of feeling, two entirely different keys. That perfectly anchors our mirror image comparison of these two serotonergic heavyweights. They're unlocking completely different doors in the human mind, all while using the exact same underlying biological hardware.
So, here is our roadmap for today. We'll be moving logically from microscopic neuroscience all the way up to modern clinical trials, covering the two faces of serotonin, transporter versus receptor, empathogen versus psychedelic, dose, duration, and kinetics, safety and toxicity risks, and finally, the clinical scoreboard.
Section 1. Two faces of serotonin, a shared origin. In popular culture, these two are almost always filed in the exact same drawer, right? They're often grouped together as party drugs or broadly lumped under the psychedelics umbrella. But when we zoom in to the neurological level, they're actually mirror images of each other. They operate on the exact same serotonin system, but it's like they're playing entirely different instruments in the same orchestra.
Section 2. Transporter versus receptor, microscopic divergence.
MDMA's signature trick is acting as a releaser. It enters the neuron through the serotonin transporter, the SERT pump, and get this, it actually runs the pump backward. It literally turns a recovery system into an efflux pump, flooding the synapse with stored serotonin. LSD takes the complete opposite approach. It ignores the transporter pump entirely and goes straight to the receptor. It acts as a 5-HT2A partial agonist, which basically means it's pressing one specific receptor key directly. So one floods the system, the other mimics the signal.
Section 3. Empathogen versus psychedelic. Different experiences.
So how does this microscopic divergence cascade into the actual human experience? Well, because MDMA reverses the pump, it unleashes an absolute flood of serotonin, alongside dopamine and a massive surge of oxytocin. This creates what we call an empathogenic or entactogenic effect. You get intense warmth, trust, and emotional openness. Crucially, neuroimaging suggests this chemical flood actually dampens the amygdala, that's the brain's fear center. But here's the absolutely key takeaway. It leaves your consciousness largely lucid. You stay oriented, you stay you.
Contrast that immediately with LSD. By pressing that single 5-HT2A receptor key, LSD acts as the archetypal classic psychedelic. It switches on cortical excitability and drastically raises neural entropy. The highly structured default mode network, which is deeply tied to your sense of self, actually begins to loosen and disintegrate. Instead of just quieting fear while keeping you lucid, LSD profoundly alters perception itself, leading to full-blown ego dissolution.
Section 4. Dose, duration, and kinetics, a question of scale.
The sheer math here is wild, and it brilliantly illustrates why their kinetics are so vastly different. 1,000 times. That is the staggering potency difference by weight. MDMA is taken in milligrams, usually around 75 to 125 milligrams in clinical settings. LSD, it's active at just 100 micrograms. To put that in perspective, it takes roughly 1,000th of the physical weight of LSD to produce a profound day-long effect compared to a standard dose of MDMA.
And look at how this plays out in practical duration. MDMA is a milligram drug that fades in an afternoon, usually lasting about 3 to 6 hours. Why? Because its effects directly track the physical flood of synaptic serotonin. Once that serotonin clears, the effect fades. But LSD is a microgram drug that lasts a full 8 to 12 hours, which is kind of crazy because LSD's actual blood half-life is only about 2.9 hours. So why on earth does a trip last all day? The answer to that mystery was uncovered in a fascinating 2017 crystal structure finding. It revealed that LSD actually gets buried deep inside the serotonin receptor and an extracellular loop folds over it like a lid. So even as the drug leaves the bloodstream super quickly, it is physically trapped inside the brain's receptor for hours on end. That is exactly what causes that prolonged all-day effect.
Section 5. Safety and toxicity risks, asymmetric hazards.
The absolutely crucial point here is that neither drug is completely benign, but their safety profiles are totally asymmetric. Let's break down MDMA first. Its risks are very acute and physiological. Because it forces a massive release of serotonin and acts as a stimulant, it can cause severe hyperthermia, so overheating, and hyponatremia, which is dangerously low blood sodium. Also, combining it with SSRIs or MAOIs can cause a potentially fatal condition called serotonin syndrome. Now, you've probably heard the old myth about MDMA causing permanent holes in your brain. That actually stems from an infamous 2002 primate study in the journal Science that was retracted a year later. Why? Because the researchers realized they had mistakenly injected the monkeys with massive doses of methamphetamine, not MDMA. The real neurotoxicity risk of MDMA is highly dependent on extreme, repeated high-dose abuse, not careful clinical exposure.
Now, let's contrast this with LSD. Physiologically, LSD has extremely low toxicity. There's literally no reliably established lethal dose in humans from the drug's direct pharmacology. Its risks are almost entirely psychological. We're talking about deeply challenging experiences, acute fear, or what people commonly call bad trips. There's also a rare risk of HPPD, or hallucinogen persisting perception disorder. Importantly, though, both of these drugs are firmly contraindicated for anyone with a personal or family history of psychosis or bipolar disorder because they can definitely trigger profound manic or psychotic episodes.
Section 6. The Clinical Scoreboard. Modern Trials in 2026.
Let's see how these opposite mechanisms are actually faring in real-world modern trials. In the MAP-1 Phase 3 trial for treating post-traumatic stress disorder, 67% of the participants in the MDMA group no longer met the clinical criteria for PTSD. That is compared to 32% in the placebo group. Because MDMA creates that lucid, fear-quieting state we talked about, it provides a perfectly fitting window for patients to process severe traumatic memories without their amygdala just hitting the panic button.
But the clinical reality of 2026 is, well, complicated. Here is the honest regulatory scoreboard. Despite that incredible Phase 3 data, MDMA's developer faced a massive setback in August 2024. The FDA issued a complete response letter, which is effectively a rejection, requesting an entirely new, multi-year Phase 3 trial because of concerns over blinding and trial conduct. Meanwhile, LSD holds a much cleaner late-stage trajectory right now. Formulated as M120, it holds FDA Breakthrough Therapy designation for generalized anxiety disorder, showing highly durable results with pivotal trials reading out across 2026. It is definitely worth noting, however, that both of these substances still remain federally illegal as Schedule I drugs. Which leaves us with this final thought. When we look at how one substance floods the brain to quiet fear, while the other selectively unlocks a receptor to temporarily dissolve the self, it's really not a competition. It is a study in medical fit. So how does understanding these two totally opposite neurological mechanisms change your view of the future of psychiatric medicine? As the data continues to roll in, it's clear the mind holds many doors, and we are just now learning exactly which keys fit the locks. Thanks for exploring the science with me on this explainer, and keep questioning what you think you know.